This is Dr. Thomas Klein. I'm coming to you from Raleigh, North Carolina. My special interest is in rare painful diseases, of which 3% of the population has, or in the United States about 10 million. Here in North Carolina we have 10 million people, so 3% of that's 300,000. So we have 300,000 people in North Carolina with diseases such as complex regional pain disease, trigeminal neuralgia, an extremely painful disease coming down your face, interstitial cystitis, a chronic inflammatory disease of the bladder, people with adhesive arachnoiditis, which is an inflammation of the covering of your spine that doesn't go away. We have people with prolonged pain syndromes following bad automobile accidents when they've had nerve injuries and nerves are not improving. We have Ehlers-Danlos syndrome. There's actually a long list, and we're going to try to put the link in the description of this video that if you wish you can go and learn about chronic and rare painful diseases and make a copy and share it with your doctor, since most doctors have never heard of most of these diseases. So the question that we get a lot at the National Pain Council and at JATH Educational Consortium is, why are we talking about people with addiction? There's a lot of animosity by pain patients for people with heroin addiction because they're being treated and the pain patients are not. Well, that's a reasonable thing to be concerned about, but what is it that we need to know about addiction to heroin? Heroin used to be sold across the counter in bottles like this. This is a reproduction, by the way. What do we need to understand? Well, the first thing we need to understand, the reason the pain patients, 80% of them, or 75%, no, 80% are being taken off their medicines, which is an immensely cruel humanitarian crisis. I mean, 80% of 10 million? Do the math. So, but why are they being taken off? They're being taken off for fear of addiction, phobia. Now, they claim they're concerned about overdose deaths, but that's really not true, or else we would have solved that problem a long time ago. We're only treating 20% of people with heroin disease. Why not more? Because secretly people don't want to treat junkies. Now, I'm using the word junkie with permission of people with heroin disease. It's not a pejorative term, it's a term that everybody understands. Because if I say, are you afraid of somebody with heroin disease, or are you afraid of a junkie, they're going to pick junkie. So junkies have been portrayed going all the way back to 1936 with the famous movie Reefer Madness. Reefer Madness was about narcotics, and they didn't even know the difference. It was actually about marijuana. It was published by a government official. Nobody knew that, and nobody's known it up until this point when we discovered it buried in some papers we were reading. So the government is afraid of addiction. We call it the fear of addiction phobia. This is what's driving everything. The people that are running around Congress and running over to the FDA saying, you be sure to put those poisons in that medicine or else they'll grind it up and shoot it up. That's very naive. Do you think that a heroin addict is going to what? Start going to church and giving up their heroin medication because they can't get oxycodone anymore? No, because there's plenty of heroin on the street. So we have to understand addiction. We have to solve the problem of addiction. If we had 100% of people offered treatment, and that is medication-assisted treatment, the only thing that works for heroin addiction, which is to give them buprenorphine or methadone. If we had 100%, there wouldn't be a demand on the streets for prescription opiates like oxycodone and Vicodin. And why is that? because it's the heroin disease people that are purchasing the oxycodone and the Vicodin. The majority of Vicodin and oxycodone are going to people with heroin disease because they would actually rather have a pharmaceutical grade drug than have to rely on street heroin. So we would suddenly not have a demand on the streets for oxycodone, that's the big one right now, because that's our best drug. It works the best, has less side effects, and it's one of the least expensive. So in our offices, we like to prescribe oxycodone. Therefore, there's lots of oxycodone out on the street because the manufacturers are making a lot of it. Where does this stuff come from? Where does this oxycodone come from? When you talk to people with heroin disease, they say there's plenty of substance out here. Plenty. So they've made no dent in the supply on the streets. None. But it's expensive because it's in demand. An oxycodone tablet that sells for 50 cents in the pharmacy is worth $30 on the street. So people stealing this drug, like tricking doctors, can walk out of the office with a bottle worth anywhere from $3,000 to $6,000 and can be sold within 2 hours. So there's a big motivation on the part of suppliers, but remember, they're supplying heroin people. So that's why we talk about addiction. If we don't understand addiction and we don't treat addiction, then nobody's going to get any more medicine. Because the government believes that medicines cause addiction. That's partially true. The big problem is that addictions have all been lumped together. A cocaine addiction is very different than a heroin addiction. They have different biochemistries, they have different what we call phenotypes, in other words, how they appear on an everyday basis. So before we can understand addiction, and before we can treat everybody with addiction, to cut down the demand for illegal drugs, we're not going to be able to treat anybody with painful disease. So if you want, we have a little description, a little paper we've written up that we will also put in the description, a link to it called the ABCs of Addiction. You can also get it on the internet by Googling Medium ABC Addiction, and you should get it. Basically, there is a class 1 addiction, which is curable. That's marijuana, most alcohol, cocaine, and amphetamines. That's a class 1 addiction, treatable and curable, no withdrawals. Bad drugs, however, in our definition for addiction, is involvement with those substances that ruins your daily life. If it doesn't ruin your daily life and you're taking these substances, you're not addicted, according to our definition. There has to be a consequence of the addiction, ruining your daily life. Class 2 addictions are nicotine and heroin and other opiates. These are brain related, they are not curable. People who have addiction to nicotine 20 years later will smoke a half a cigarette and are hooked again. So very important to know that they're different, and this little paper that's been written explains that difference. Now, once we understand the difference, a lot of things become clear. One, why didn't it work to outlaw all uses of heroin, including for us doctors? It's a good drug, it's kind of like oxycodone. So they outlawed it in 1925, here we are 100 years later, and we've made what kind of progress by limiting the substance? Zero. I mean, a lot of money's been spent. That's because the nature of the addiction is not understood. If heroin was in class 1, you could potentially stop the addiction by limiting the supply. If you limit the supply of cocaine, and there's no cocaine around, then people are not going to become involved with cocaine to the point that it's ruining their daily life. Not true for heroin. That's why very important, class 1, class 2 addiction. Heroin is a different and very real disease. It's lifelong, and we need to learn to treat it properly. And once we treat it, there's going to be no street demand, and we're going to be able to treat our patients again. So that's kind of, in a nutshell, why we are also interested in addiction. Our primary focus, of course, at the National Pain Council is to restore treatments to the way it was before. And the overall goal is for equity in treatment for all diseases, for all people. So if you want to join the National Pain Council, you just go there. You can just plug it into Google. There's no cost. You will be on a confidential list. We don't sell people's names. We don't recognize people's names. It's completely, this is a private organization. And we are still working on notifying the White House and the new director of the CDC about your stories. And you can go to suspendcdc.org and get instructions on how to do that. So thank you and good evening.